Ladies, can you hear me? Yeah, good. Okay. Audrey, I just saw your email, so
That's okay. It's fine. I was
wasn't
going to
trying
come to
to
class
dodge
if you didn't
you.
respond.
I had quiz practice
No,
and
it's
then
okay.
I left my phone in my office.
Yeah, it's fine.
Yeah, so okay. I can email you guys a quiz if that'll work the best. I'll do that after class then.
So you're going to email us the quiz after class?
Yeah, I'll mail it to you after class.
Okay. And then, do you want us to just like write our answers on a piece of paper or something?
No,
And then like send that to you?
take the
Or just
Word
respond?
document and highlight your answer in some soft
Okay.
color, yellow,
Okay.
soft green, soft blue, and then save that and then send it back to me as an attachment.
Okay. Okay. Awesome. Thank you.
Okay.
Is there a time you want that done by, like right after class?
Well, definitely before Monday.
Okay.
All right.
Okay.
Oh, no, Morgan,
Awesome.
not
Thank you.
Too.
Yeah, that's Audrey.
Yeah, me and Keegan are also in quarantine.
Oh, good night. Okay,
When do you guys get out? Sunday?
it happens.
Everybody gets out Tuesday, right?
We're
Hang
free
on.
on Sunday.
How do you guys get out on Tuesday, but Mia gets out on Monday with me? I mean, you guys get out on Sunday.
Yeah, Sunday night. I don't know. Audrey and Caitlin, what about you guys? Natalie!
Not until the 18th.
Yeah.
Got a home in Adria, people quarantine.
Yeah,
so
we
No!
everybody
literally
wait for them.
My RA was like, it's like 6:15.
The class
My
is
RA
waving
was
to
like,
you.
my RA was like, do you think you could get out like before your Zoom class tonight?
They are
And I was
just
like,
dripping with sympathy for you.
Oh my god, bro, that sucks.
I know.
Yeah, we're in here for a while.
So here's what my wife made for everybody tonight.
No, I miss the Wednesday night treats. Dang it.
Rice Krispie treats. So I'll send you one in the mail or? No, I won't do that. So hey, more for you. So,
Thank you. Thanks.
guys are all by yourself. Good night, Clarissa. Two-fisted dinner there. Oh, it was free yesterday. Oh. Okay. might have it with me. I'll have to check. Yeah, I answered it. No. Oh gosh. People are having trouble with chapter 6 too. I'm wondering if I should just take those two and just redo them. Yours was 2, and then Emily was having trouble with 6, even after I redid it. Which, I mean, that was just downright weird. Are there any more quizzes out? No? Yes, okay. That's fine. Thank you. Okay, a little bit of housekeeping stuff before we get started. Some people are having trouble with a couple of the unit tests. Sydney had some issues with chapter 2. And then Emily, you had some trouble with chapter 6, even after I redid it. You're still having trouble with it. Anyone else having trouble with chapter 2 unit test? You too? Sydney sent me a screenshot where it counted her wrong on one answer, and then when she gave that answer the second time, it counted her wrong again, even though it said it was the answer the first time, and then it reneged on that the second time, and then you had trouble with 6. It was
I had the exact same thing as Sydney. I know exactly what she's talking
Morgan,
about.
you too? Was it
Yeah,
chapter
same
2?
as Sid. Yeah.
Okay, maybe I need to just redo chapter 2 again.
I think it could be the way that they score that question because it was multiple choices. Like there were 2 answers that were right, but if you took a wrong answer, it was more wrong, if that makes sense.
Yeah, no, that does make sense. Are you having any trouble with chapter 6?
I didn't take that one yet.
You haven't taken that one yet. Okay.
I did like that practice assignment for them to do also, and like I got everything right, but at the end it's just 0 on a 0.
Right, because the practice test doesn't, that's not scored, it's just for your practice. Right. Well, then let me take a look at 2, and if 2 is being a stinker, I'll just pull it and redo it. I try very hard to make sure it's just multiple choice, because if it's fill in, you could put a comma in the wrong place and it'll mark it wrong. And there's a tolerance setting. Even if I make the tolerance setting as permissive as possible, it still does that. I don't know why. So with multiple choice, that tends to not be the issue. Morgan, I don't know if you heard Morgan, she said she had trouble with the same question Sydney had trouble with, and she thinks it's due to the way the software scores it, whether it's more right or more wrong or whatever. Anyway, I'll. Yeah, and then that whole answer snafu thing was goofy. That just ought not be. So I'll take a look at that and I'll see what I can do. Okay, we looked at glaucoma medicines. So let's rattle off categories of glaucoma medicines. Give me a category of glaucoma medicine. Beta blocker, okay. Give me another category. Anticholinergics, yes. And give me another one. Prostaglandins, very good. Another one, Abby.
Carbonic anhydrous.
inhibitors, carbonic anhydrase inhibitors. Very good. You leave anything out, you two? Alpha 2. And any more? Rho? Anti-Rho kinase? That one. That one, that's the new one, the extensive one. Okay, so those are your glaucoma meds. They're for wide angle glaucoma. For the narrow angle occurs if the iris flops down against the trabecular meshwork so that it can't drain. So essentially the drainage area is blocked. That has to be fixed with surgery. You'll do drugs usually before surgery, but that's not treatable with drugs. You have to surgically remove that. Usually it's treated with lasers. Use lasers to poke holes in the part of the iris that's collapsed against the trabecular meshwork. After going through any of that, do any of you have any questions on any of the glaucoma drugs? Was that clear as mud, or any questions on any of that? No? Okay, then we looked at treatments for wet macular degeneration. They're the VEGF inhibitors. They're injected into the retina. They're injected intravisually. And you put a bolus. Usually with wet macular degeneration, the issue is with the pigmented retina, that pigmented retinal epithelium underneath photoreceptors. Those cells start to go south, and because the photoreceptors depend on those cells so much, if they die, the RPE cells die, the photoreceptors die. And then you get this material that deposits under there called drusen. And that drusen is just dead cell debris and oxidized photopigments and stuff like that. And that material tends to kill more photoreceptors. That stuff is toxic to the other photoreceptors. So the key to treating that is not letting it spread. Also, not letting blood vessels make new islands of vessels that will tear up more swaths of photoreceptors. That's what these injections do. They prevent VEGF, the vascular endothelial growth factor, from doing just that. That's why you inject them smack into the eye. Then there's a photodynamic therapy we talked about with the porphin, and that essentially takes these new blood vessels, makes them sensitive to lasers. You hit them with the laser, and the blood vessels essentially dissolve. All right, questions about any or all of that before we move on? No? Then let's take a look at bacterial conjunctivitis. Bacterial conjunctivitis. Now, bacterial conjunctivitis is what you commonly call pink eye, right? Pink eye. If you work in family medicine or peds, you'll see 50,000 cases of pink eye in your day. It's really common. Also, when one kid in the family gets it, the other kids get it too. Because kids are touching eyes and then they're poking each other in the eye and then they scratch their own eye and stuff like that. And sometimes even the parents get it. So the treatment of choice usually are antibiotic drops. The drug of choice usually, it depends on the severity of the pink eye. Sodium sulfacetamide is very well tolerated, but it's not very particularly strong. But if you have a weak pink eye, it'll work just fine. So that drug is not usually much of an issue. You can also combine it with a steroid to reduce the inflammation, and those are combinations as well. When it comes to the aminoglycosides, the drug of choice is tobramycin. It's very well tolerated. It's better tolerated than neomycin. Neomycin comes as an ointment. And when I was a kid, we had this sycamore tree. And the sycamore tree, I don't know if you've ever seen sycamore tree pollen. It makes this big tufts of pollen. I used to get that on my eyes, and my eyes would get really puffy. And my parents would pin me down at night and take Neosporin ointment and stick it on my eye. I hated it. And it did the trick. But I'd wake up with a really red, dry, swollen eye the next day. Tobrex drops, which is tobramycin, won't do that. You can also combine it with dexamethasone, that's Tobradex, and that works fine. Gentamicin is also used. These drugs are very inexpensive. If you have a family, low income, not very good insurance, these are good drugs to go with. Yeah. No, usually these are twice a day. Sodium sulfacetamide is 3 to 4 times a day, depending on the severity. You usually use them for anywhere from 7 to 8 days. If it's really bad, 10 days. So you don't, with conjunctivitis, you don't want to use oral antibiotics because the penetration of the antibiotics to the conjunctivitis is terrible. All right, and then you have lots of other ocular preparations. Trimethoprim is broad spectrum, but that's a last resort if you don't respond to anything else. Zithromycin comes as an ointment, and it's very good for chlamydia. If you have babies who have been born to mothers infected with chlamydia, they can get trachoma. The trachoma can permanently scar the conjunctiva. The baby will be blind the rest of its life. And the azithromycin ointment, very good for that. And then the ocular fluoroquinolones. Those are the drugs of choice for contact lens wearers. Contact lens wearers will tend to get Pseudomonas aeruginosa growing in the contacts, and fluoroquinolones are very good at killing Pseudomonads. Xylet is another combination drug with tobramycin, and then you've got a bucket full of different combinations. Down there you have Maxitrol. Maxitrol is definitely one of the ones that's used the most. Maxitrol is also used for blepharitis. That's infection of the eyelid. Word of wisdom about steroids on the eye. If you put steroids on the eye, make sure it's not long-term because steroids will raise intraocular pressure. So steroids should be used short-term. If someone's had eye surgery, and usually they'll have methylprednisone eye drops that they use, the surgery has a higher risk of raising intraocular pressure than the steroids. So use the steroids, but you just will only use them for a period of time. That's pretty much ocular antibiotics. The preps, usually these preps, when you go to the pharmacy, they very often will have them in the refrigerator. It's very important, especially if there's a steroid mixed in, you shake it. Because the steroid very often will separate from the antibiotic. Make sure you shake it before you apply it. Otherwise, you won't get any steroid. Or you make it just steroid. Very good. Viral conjunctivitis or viral karyoconjunctivitis is almost always caused by herpes simplex virus or by varicella zoster virus, particularly in the case of shingles. Now, If someone gets a shingles infection in the eye, you never use steroids. The steroids will make it worse. So the drugs of choice are ocular goncyclovir or trifluridine. Goncyclovir is better tolerated and is usually the drug of choice. Ocular acyclovir is available in Europe. It was discontinued in this country because one, acyclovir is not very soluble. So you put it on your eye and it tends to precipitate out. And then it feels like you're blinking on glass. Not good. And then two, it's just not as effective as against the virus as gencyclovir. Very good. Okay. Oh, there we go. Oh, I think your book talks about ocular chloramphenicol for the eye. I have no idea why it does that. Ocular chloramphenicol has not been used in this country for the last 15 years. It's used overseas. It's not used in this country. Chloramphenicol, let me say this about chloramphenicol. Chloramphenicol is only used if the benefits to your patient vastly outweigh the risks. And by risks, chloramphenicol can cause aplastic anemia. And it can also, on your eye, it can irritate the eye pretty badly. So ocular chloramphenicol is just not used. So wherever that's listed in your book, just scratch it out. Not used. Okay. That's ears. We'll go to ears pretty soon. Dry eyes. Dry eyes. So there's two products that are available by prescription. There's the Restasis, which is topical cyclosporin. How cyclosporin works for dry eye syndrome is completely unknown. But it's safe, it's well tolerated, but it takes several weeks to start working. Then there's Lefitic. Yeah, question? Yes. Cyclosporin is a drug typically that's used as an anti-transplant rejection drug, but it's taken orally in that case. In the eye, the absorption, systemic absorption of cyclosporin is very poor. So it just works on the surface of the eye, and that's it. The drug is far too insoluble to be absorbed very well. Orally, yeah. And it has a lot of side effects. Well, when we cover immunosuppressants, we'll cover cyclosporin. But for the eye, it's a different story. Works really well for dry eye. And it's a very low concentration too. Lefitigrast, as you can see, antagonizes this LFA1. Again, how it works is not clear. It might reduce surface inflammation, and that might be a part of dry eye. This is a really new drug, so it's really expensive, and there's just not as much data on it. As more data gets collected, people will probably use it more and more. In the papers that were published on its use, it seems to be quite safe. There are lots of artificial tear products you can buy over the counter. Most of these are lubricants and wetting agents. So they're usually hydroxypropylcellulose. They're usually polyvinyl alcohol. There's Providone. Providone is a disinfectant in these. There's lots of these. I'm sure some of you have probably used these from time to time, especially nursing students who have to stare at stuff forever. your eyes start to, because you have the lights, your eyes get really dry. Or if you fly long distance, because of the ventilation, that can make your eyes really dry. You guys are staring at me like I'm from Mars. That's never happened to any of you? Must be an age thing. Because it happened to me when I started getting older. When I was younger, it never was a problem. Now, when I fly on planes for a long period of time, my eyes get really dry, really red. So there's lots and lots and lots of over-the-counter products. I basically got tired of listing them and just put etc. These are well tolerated, but if you overuse them, they will irritate the eye. Next, we have ocular antihistamines. Now, I'm sure some of you have experienced red eye during that time of summer or spring when your favorite plant comes out, drops its pollen, and you start sneezing, and your nose is dripping, and your eyes are watering, and you're miserable. Well, there are drops for that. And some of these are over the counter, some of these are prescription. So olopatadine is now over the counter. That is a very, very good ocular antihistamine. It used to be by prescription called Patanol. Now it's called Patent-A, and it's over the counter. Number 7 and 8, ketorolac, ocular ketorolac, and ocular ketotifen. Those are both over the counter. Azole-Aston is by prescription. So is the alcaftadine. If you test these head to head, they all seem to be kind of equally effective. The prescription ones has a higher concentration of the drug. If you overuse these, they dry out the eye. Other than that, they don't really do a lot of adverse reactions. So these work quite well. Mydriotics. What do mydriotics do? Dilate the pupil. Dilate the pupil. Which branch of the autonomic nervous system is responsible for dilation of the pupil? Sympathetic or parasympathetic? Sympathetic. Sympathetic. What is a neurotransmitter used by postganglionic sympathetic neurons? Oh, come on, guys. It wasn't that long ago. You don't remember this. Remember this now. Norepinephrine. Norepinephrine. So these drugs are going to mimic the effects of norepinephrine. These are what the eye doctor uses to dilate your eyes. And topicamide is probably the one that's used the most. It's very inexpensive. Because they dilate the pupil, they'll cause light sensitivity, and they tend to sting going in. If you've been to the eye doctor and had this done, you remember the sting when they got put in. So you can see the retina for retinal exam. I have to get this done every year. My vision goes blurry and I get really light sensitive. Then what do? put a great big bright light in my middle of my eye and say, look at it. Yeah, but it's got to be done. So that's why you dilate the pupil so you can see into the retina. After the age of about 45, you should probably have a retinal exam every year. And if you're diabetic, you should have a retinal exam every year, period. Because diabetes, if you don't control your blood sugar, causes death of the cells that surround the capillaries in the eye. And those cells, when they die, they cause the vessels to get leaky, to get edema of the retina. And then, because you get highs and lows in blood sugar, those vessels then will start to branch out. And as they branch out, they'll take out swaths of photoreceptors. You'll start getting holes in your vision. And then because of the swelling of the retina, your vision is going to get really blurry. And that's irreversible. You can help it by tight blood sugar control. Tight blood sugar control. So, yeah. Myotics. Myotics make the pupil go to a pinpoint. And that is the work of the parasympathetic nervous system. What's the neurotransmitter of postganglionic parasympathetic neuron? Say it again? No. Sorry? Acetylcholine. That's correct. Paige is right. Acetylcholine. So these drugs mimic acetylcholine. They bind to the muscarinic receptors in the ciliary muscles of the eye. Then you have eye anesthetics. The main one is definitely lidocaine. These others, proparacaine and tetracaine, last longer. But lidocaine, A, is cheap. B, lidocaine, the pharmacokinetics of lidocaine don't vary very much from person to person, and they're very well understood. So because of that, lidocaine is usually the go-to for eye anesthetics. Or use tetracaine. Tetracaine is longer lived. Abby, you can redose with lidocaine very easily. If you're doing surgery, say around the orbit or something like that, re-injecting takes seconds. Or if you're just working on the eye itself, you can just put drops on and boom. So, okay, questions? Lidocaine too does not irritate the eye very much. That's the other reason for using it. Ocular antifungals. Fungal infections of the eye are not very common. But if you do get fungal blepharitis, conjunctivitis, keratitis, your go-to drug is natamycin. An ocular form is this naticin. This drug is extremely safe. It's even used as a food preservative. And it tends to work quite well. Finally, how many of you remember from pathophys what Graves' disease is? Yeah, why? No, it's not the intraocular pressure. Yeah, thyroid. What's wrong with the thyroid, Anna? Hyper, why? Because you make an antibody to the thyroid stimulating hormone receptor that perpetually activates it. So the thyroid is constantly kicking out thyroid hormone. That causes a fat pad in back of the eye to enlarge, and it causes the muscles that keep the eye in place to swell. That's what pushes the eyeball out. That's called exthalosmos. It's very dangerous. It stretches the optic nerve, and you get papilledema, you lose your vision permanently. So there's a new drug. This is really new. And it's called teprotumumab. Say that fast 5 times. Teprotumumab, the trade name is Tepeza. And it turns out the thyroid hormone stimulates insulin-like growth factor 1. And if you inhibit that, you can save the eye. And this is the only time it's used, but Graves' disease is such, if any of you work in family practice, you'll probably see a few cases of Graves' disease. You probably have opportunity to either use this, or if you work in an ED, you may need to use this as well. There are some side effects, as you can see. It's not a safe drug, but hey, the trade-off is going blind. So high blood sugar, hearing problems, taste changes, those will go away. Blindness, that won't go away. Abby? Graves' disease is reversible. Usually what you do is you kill the thyroid by giving the patient radioactive iodine. Then they need to be on thyroid medicine the rest of their life. But that's better than, you know, popping an aneurysm and dying. Because that's what that kind of hyperthyroidism can do. Very good. Any questions about eye medications, anything? You want me to go over again? Folks on Zoom, you guys good? Any questions? Okay, I'll take that to mean you're fine. All right, let's go to the ears. Ears. Ear preparations tend to be much more viscous than ocular preparations. Ocular preparations are pretty aqueous. Ear preparations are more viscous. Can anybody guess why? So it'll stay in your ear. You put watery stuff in your ear, you stand up, what happens? It flows right on out of your ear. So the ear preps will have glycerol or something like that in them. So swimmer's ear is usually caused by Pseudomonas aeruginosa, most commonly. And there are very good ointments. Some of those are listed here for that. Many of the drugs of choice here will be your fluoroquinolones, largely because they tend to have very wide coverage. And if you get a mixed infection in the ear, these will tend to hit it. Yeast infections of the ear are also seen in some cases, particularly if the ear is constantly wet for whatever reason. You get a lot of wax build up and that traps moisture. That can promote a yeast infection. And there's nystatin, clotrimazole, flumetazone, and then aluminum acetate, so-called Burroughs solution. And those will treat those infections quite well. And these are all by prescription. Things for cleaning the wax out of your ears are all over the counter. And this is carbamide peroxide. If you have eustachian tube dysfunction, that's usually because the tube is plugged because of mucus. So cetirizine and diphenhydramine, those are antihistamines. You can also use decongestants, but recent research has shown that decongestants do not speed the recovery of such things. So decongestants very often aren't used. For the pain, you can use non-steroidal anti-inflammatory drugs like ibuprofen, acetaminophen. And then Meniere's disease, you have recurrent vertigo, ringing in the ears. The drug that's used off-label is Valium, diazepam. And that's given orally. Remember, diazepam is addictive. It's habit forming. So in the 1980s, veterans hospitals gave a lot of diazepam out to veterans who were probably suffering with PTSD. A lot of vets got hooked on it. And getting off diazepam is hard to do. Withdrawals are nasty. And unlike opiates, where you have drugs you can give to take the edge off, with diazepam, there aren't a lot of drugs to do that. So be careful with diazepam. All right. And that, my friends, is the eye and the ear. Let's see. All this business about how to instill eardrops, you learn that in other courses. You don't need me to tell you about kids. You go down, adults, you go out. You don't need me to tell you that. Blah, 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 blah. You get the picture. All right. Questions on anything? No? Okay. Let's take our break now, and then we'll go to skin, and we can break out the Rice Krispie treats. My wife made sure there were 24 for everybody. But since there's so few of you, I think each person is going to get 2. These are sticky. We need napkins. I'll get napkins. Just where's the napkin? Used to be tons of that. Come on, you. There. Okay. Hey, guys. Go ahead, have some. Does anybody know where Haley is? She's not on Zoom, and can anyone text her for me? Say, where are you, dear girl? Does anyone have her? Donnelly? She's not here. She okay? So she's okay, as far as you know. Okay. Yeah. Ah. Okay. Okay. Especially with the weather being the way it is. These are good. Allison, do you guys play some sort of league, or you guys?
We had a tournament last weekend, and yeah, 3 more, I think. One in February and 2 in March.
It's a league.
I don't think so. I think they're just like teams that are like whatever coach can schedule. I don't want to follow them.
Just to keep you playing and to keep you sharp.
Yeah.
Feel free to have seconds, please. There's plenty left. Yep. Clarissa's brave. Okay. You go, girl.
I don't know if you would have done that.
No, I don't. Yeah, don't. Just don't. You called Emily? You got your coat on and. Very good. If you want to go up during class and get some more, I won't be offended. Okay, let's talk about skin issues and the types of medications that might be necessary for various types of skin issues and things like that. The first one I'd like to talk about are, of course, sunburns. These are very common. UV exposure is linked to photoaging and skin cancer, and of course, sunburns. The frequency with which you get sunburns when you're younger, particularly if you're very fair skinned, can increase your risk of skin cancer later in life. And sunburns, therefore, can be reduced, number one, by properly covering your skin, two, by the use of suntan lotion or sunscreens. So this handout talks about the different types of sunscreens, well, rather the different type of sunscreen components that are available. So SPF means sun protection factor, and it is an inverse number. So 15 means 1/15 or 7.5% of all the sun hitting you actually penetrates the sunscreen and is hitting your skin. If the SPF is 50, that means 1/50th of that sunlight is hitting your skin due to the activity of that sunscreen. And SPF 100 means 1/100th of all that sunlight hitting you is actually hitting your skin. So it's an inverse number, and some of the components will inhibit different components of UV light. There's UVB, which is the highest frequency, shortest wavelength. There's UVA1 and UVA2. Those are less energetic, a little longer wavelength, a little lower frequency, but they can still do damage to DNA and other things and what have you. Now, the majority of materials in sunscreens are organic compounds. These compounds are absorbers of either UVB or UVA1 or UVA2 or something like that. Let's just go over just a few of these. So first, there's avobenzone, and it effectively absorbs UVA1, also some UVA2. In general, it's a good UVA2 absorber. So if you have avobenzone in a sunscreen, UVA is largely covered. Then it has this other feature where it tends to break down in the sun. So it tends to decrease its efficacy. So essentially by 1 percentage point for every minute you're out in the sun. So if you're in the sun for 10 minutes, that's not a big deal. If you're out in the sun for an hour, no, it is a big deal. And you need to reapply. However, you can increase the photostability of avobenzone by combining it with other filters that are photostable, and that will increase its photostability. So this is a good compound that plays well with others, and if you combine it, its stability is increased. Then there's this stuff, octinoxate. This is a very potent UVB absorber. And if you have this in your sunscreen, UVB is largely covered. Then you have these two compounds, similar compounds in some ways, octisalate and homosalate. These are weak UVB absorbers. However, if you combine them and then combine them with other things, they will additively work together to shield UVB. So here's some examples. Some of you may use sunscreens like this. So Blue Lizard, as you can see, has the octinosalate, and then some other stuff too. Kiss My Face Sun Spray Lotion has the octinosalate, also with some other stuff too. And then Panama Jack, that's got the octinosalate as well, yeah, right here, and other stuff as well too. Those are just some examples. What I did was I went to websites and I pulled what was on these off and just basically put these on to give you examples. I won't include all sunscreens, but just some examples of ones that have these compounds in them. And I tried to put the SPF on there as well. Octocrylene absorbs UVB and it's very photostable, so it doesn't break down. Also, when you take octocrylene and combine it with other agents, it increases the photostability of these other agents. So we talked about this other agent here that tends to break down. If you combine that with something like octocrylene, it will increase its photostability. And sure enough, so Banana Boat Sport, which is this, that has the octocrylene and the avobenzone. You combine the two, the photostability of this increases the stability of the avobenzone. Then there's the Aveeno Active Naturals. My youngest daughter really likes this stuff. That has also the octocrylene and also avobenzone, and then octisalate and homosalate together to shield out UVB with the octocrylene. Then there's a capsule that absorbs both UVB and UVA2. And here's an example of one that uses a capsule, and it's this stuff called anthallose. This stuff is pretty expensive, from what I can gather. That's a little overview of some of the stuff on your sheet here. Now there are some inorganic compounds. They contain titanium dioxide and zinc oxide. So these are formulations. They do not penetrate the skin because they're in little microspheres. And they've been shown to be safe for children. In fact, they are the preferred sunscreen for children. And they also are safe for not just pregnant women, but also for women who are lactating as well. Now, some of these organic compounds, research has shown on animals that some of these can act as estrogen mimics. However, there's no evidence that any of these act as estrogen mimics in humans. So yes, you'll read stuff on websites saying, don't use sunscreen. If you want to have a baby, it'll lower your husband's sperm count and stuff like that. There's no evidence of that at all, none. So just don't believe that stuff. And if patients ask you about that sort of thing, tell them, no, that's not the case, and use it because you don't want skin cancer. Two of these compounds on here, octinizate and also oxybenzone. Those have been banned in Hawaii because research has shown that they cause bleaching of the coral. So those are not used in places where coral reefs are abundant. So in Australia as well, with the Great Coral Reef, they banned sunscreens that contain those compounds. So those two compounds you might want to mark on your sheet. They can cause some environmental damage. Yes? Sure. So the oxybenzone, and then the octinoxate. Octinoxate as well causes coral reef bleaching. So octinoxate is a cinnamate and oxybenzone is a benzophenone. Now, the organics are not recommended for small children. There's just not enough known about the absorption in kids, what they can do to kids. So what is recommended are the inorganics because they are not absorbed. And they're very effective. You had a question back there?
Yeah, how do they regulate the sunscreen?
They don't let them be sold, essentially. So I guess if you drive a long distance and you have that in your backpack, unless a conservation officer is checking. I don't know if you know this, but conservation officers are under the Department of the Interior. They carry a badge and a gun. They can not only arrest you and throw you in the pokey, they can also confiscate things like your car and stuff like that, or a violation of certain laws. Those guys have a lot of power. Several studies have shown that routine sunscreen use will decrease the risk of skin cancers, in particular, dangerous skin cancers like melanoma. So wear your sunscreen. Questions about sunscreen or anything like that? Okay. Now we go to insect repellents, because they can cause skin issues too. So mosquitoes, need we say more about mosquitoes? The female mosquitoes, male mosquitoes do not bite you, females do. Male mosquitoes feed off the secretions of plants. So do females, unless they're laying eggs. Females need the blood in a blood meal to make eggs. These disgusting things over here on your left, those are chiggers. And a chigger is a nymph, and it burrows into your skin, and it causes some really nasty welt-like reactions. You get them around rivers and things like that, and they are nasty. Yes? A tick, no. They're different than a tick. Ticks are they're arachnids. Chiggers are actually insects. Okay, DEET. Diethyl M toluidine, or toluamide, excuse me. That is DEET. DEET is very effective against mosquitoes and ticks. It also repels chiggers, and fleas and gnats and most flies. It'll protect you for up to 12 hours. On the average, DEET is well tolerated. However, some people can get mild skin irritation. Urticaria, that is medical speak for someone said it, a rash, very good, a rash. Some people can get bullous eruptions. Those are not common, but it can damage synthetic fibers and plastics on eyeglass frames and watches and things like that, because it's an organic salt. Yes. Very little. Yeah. It gets a very small amount of it gets absorbed, and that small amount that gets absorbed doesn't seem to do any damage. Picaridin is a product that is actually quite safe. It comes in 5 to 20% concentrations. It's effective against mosquitoes, ticks, fleas, flies, and chiggers. It can cause skin and eye irritation, but is better tolerated than DEET. It's not greasy, doesn't damage plastics, albeit it will dissolve vinyl. If you ingest it orally, you get a sour stomach, and that's about it. Because of its safety, the American Academy of Pediatrics recommend Picaridin over DEET for kids. Yes. Last longer. This is called IR 3535. I don't make the news, I just report it. And this is a synthetic version of beta-alanine. It repels mosquitoes, deer ticks, and flies. So it's very good if you're hiking. It's available in 7.5 to 20% concentrations, but only concentration at or above 10% are effective. It can cause eye irritation and may damage clothing and plastics, but does not seem to cause skin irritation. Or if it does, it only does so rarely. Because they can lower the price and get the public to buy it. That's marketing, it's not illegal. That's why, caveat emptor, that's why if your patient comes to you and says, oh, we're going hiking for the weekend, and you hear where they're hiking, you say, a lot of deer ticks there, Lyme disease. And so you start suggesting some insect repellents. And she says, oh, I got this stuff. She pulls it out. You look at it and you say, what percentage is that? Let me read. You discover it's 7.5%. You need to tell her you need to buy different stuff because this is not going to work. Basically, it doesn't work. Yeah. I got that off Consumer Reports, which I trust. Consumer Reports tends to do pretty rigorous tests. Oil of lemon eucalyptus. Oil of lemon eucalyptus. When I did a mission trip this summer at Santa Elena, they used a lot of this because there's eucalyptus trees all over the place there. This will repel mosquitoes, ticks, gnats, and biting midges, which is great for the UP. You get about 6 hours of protection, about as effective as DEET. Some people are allergic to it. So some people, they put it on and they get hives. So you might want to skin test, just patch test first before you use it. It's not recommended in children. And Emily, and this does get absorbed to some degree by the skin. Doesn't seem to be much of a problem in adults, might be a problem in children. So it's not recommended for children. Undecanone. This comes from wild tomato plants. Wild tomato plants. This is available as a product that's called BioUD. 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 Repels mosquitoes for 4.5 hours, ticks for 2 hours. This stuff has a really strong odor. You can take it, fine. If you're going to be all alone and nobody cares, fine. Otherwise, might want to try something else. Citronella is not effective against ticks. And it's only effective for 2 hours. And some people get really bad skin irritation from it. Now, permethrin is used to impregnate sleeping bags and sleeping nets and other things. It remains active even after multiple launderings. Repels mosquitoes and ticks very effectively. No adverse effects that have been detected. It's very safe. And it's safe for both pregnant and breastfeeding women. This stuff gets used a lot in Africa for the, well, in South America, they call them moscaderos, the mosquito nets. Wearable devices, they don't work. Save your money, they don't work. Oh, on our camping trip, I bought the kids a bunch of those bracelets. What are you going to tell her? They don't work. Put some Bacardin on them or something like that. Yeah. They don't work either. Yes. Because it seems like a good idea. And people think the idea makes sense. The problem is science doesn't work on intuition. Intuitions have to be tested, rigorously tested. Oh, that seems like it should work. Well, yeah, a lot of things seem like they should work. But when you rigorously test them, they may not work. I get this guy online, kept going at me, going at me, going at me. Masks cause you to pass out. Masks decrease your oxygen. I said, look, I can take a pulse ox and put it on your finger with and without a mask. I can do that to 50 people. There won't be a difference. Trust me, I've done the experiment. Well, people aren't going to believe it. I said, I don't care. That's what the data says. In science, you follow the data regardless of where it leads you. And so should you. In fact, write that down. Follow the data wherever it leads. Yeah, those don't work either. Really. The diameter of repulsion you get varies pretty wildly. Yeah, it varies pretty wildly. Also, the fumes from it can irritate respiratory passages. Which one of these is safe? Yes.
So what would be like your generic like you see
Like what you get at Lowe's, or most of those have DEET in them. And they'll say, in fact, I hope, if anything, this inspires you to start reading ingredients. DEET. I use DEET. Citronella doesn't work at all for me. And mosquitoes love me. They love me. They love me, love me, love me, love me, love me. I use DEET. Picardin? Depends on the product. Tends to be comparable. Yeah, natural. What does that mean? Yeah, I don't either. So, if it's not any of these products, I wouldn't use it. So, which of these are safe for pregnancy? Each of these here have been shown to be safe for pregnancy. All of these are safe to use during pregnancy. Questions on insect repellents? Yes, Allison. Mosquitoes are attracted to CO2. They're also attracted to hormones, in particular sex hormones. So that's why women at different times of the month will actually get bitten by mosquitoes differentially. If you're, excuse me for being crass, but if you're bleeding, they can smell that and they're attracted to it. So a menstruating, well, again, I'm not trying to be gross, but you're going to be nurses, doggone it. You're going to see it all. If you're menstruating, you'll probably get bitten more because they can smell the blood. And they also smell, the biggie is CO2, but also certain molecules in your sweat. They might be attracted to amino acids, things like that. And different people's sweat physiology and chemistry is different. But like I said, they love me. We went on a camping trip, let's see. My wife was bitten twice. Stacy, my daughter, was bitten 3 times. I was bitten 34 times. They love me. They love me, love me, love me. So yeah. That's one of the times when it's not nice to be loved. Yeah. Okay. Atopic dermatitis. For atopic dermatitis, tier 1 is take a bath and use an emollient, a skin hydrator. There's lots of these available on the market. These tend to work very well and they're very safe. Lots of OTC options. These are just a few. Take your pick. There was a hand back there. Am I? Okay. And if you're going to raise your hand, say you'd include my brand, deal with it. Yeah. That's what I use. I don't have a ton of trouble with dry skin, except under my arms. That's the only place where I have trouble. So.
I found like, this I can say, it's a lot, like, more moisture, and so then when I come over here, my skin is like.
Well, nurses are washing their hands 20, 30, 40, 50 times a day. Nurses have chronically cracked and drying hands. And so moisturizing is going to be really important because you're going to forget to. Also, don't use gloves with powder. The powder makes it worse. And hospitals usually, the other problem with powder gloves, you put them on and then you get this cloud of talc everywhere. So, yeah. All right, if that doesn't work, where do you go then? Topical treatments, and the treatment of choice are your corticosteroids. Again, lots and lots of options with corticosteroids, and they come in super high potency, medium high potency, medium potency, medium low potency, and lowest potency. The lowest potency, in fact, they're all available over the counter. That's your 1% corticosteroid, hydrocortisone, that sort of thing. The rest of these are going to be available as a prescription. So this is just one particular compound here that you can get. There's lots of these. And you've seen these. Some of you, maybe even of you have used them.
Should topical drugs that are just for localized drugs, do they have to use the therapeutic effect? Like how it does in the drug?
No, they work locally. They work locally. And that's actually a good point. With local steroids, unless you use them for a really long time, the medium and low potency topical steroids are usually not an issue. They can cause skin atrophy if you use them for a long period of time, but they usually are not an issue. The high potency ones, you're going to get more absorption, and those can cause systemic effects, especially if you use them for long period of time. Let me just read you some of the super high potency ones. So there's this stuff called halobetasone. Halobetasone. Halobetasol, sorry. Halobetasol. Halobetasol is a super high, very high potency one. There's also clobetasol. That's another super high potency one. For the high potency, there's betamethasone. That's high. This is super high. And this one is 0.05%. This one is 0.05%. And they're not very concentrated, but they're potent. They're really potent. This one is also 0.05%. And blah, 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 blah. There's lots of these products. I don't want to read you the riot act on them, but these can definitely quell atopic dermatitis. So the adverse effect is that you can get bruising, purpura's bruising, skin atrophy. That's a biggie with long-term use. Telangiectasia, anybody know what that is? When you get those veins that pop out and get red and you get those little blood blisters, that's telangiectasia. Because the skin gets so thin, the blood vessels pop out. That's telangiectasia. And then you can get permanent striae or stretch marks. Because again, the skin gets thin, it gets stretched, and you get a stretch mark. If you apply them to the eyelids, again, they can raise intraocular pressure and cause glaucoma. And they can also potentially cause cataracts because they cause the lens epithelium, they cause the lens epithelium to divide. And it thickens, and they deposit more protein in the lens, and that causes the cells, the lens cells then to die and then become opaque. Renal suppression risk is only a risk with the higher potency ones. Low to medium. So this range here seem to be safe during pregnancy and during breastfeeding because they're just not absorbed very much. Questions on the steroids? Calcineurin inhibitors are an immunosuppressor that are used for transplant patients. These are topical. These don't have nearly the side effects that they have when they're used systemically. So the one that's typically used the most is pimecrolimus. That's the one that comes with the product Elidol. You might have seen the commercials, the really dumb commercials on TV for Elidol. There's also topical tacrolimus. That's protopic. It also comes as a generic. Here's a generic tacrolimus. You can use these on faces and intertriginous areas. I got my I and my N mixed up here, sorry. 2 to 3 times weekly. They don't cause skin atrophy. That's the beauty of these. These are more expensive than your steroids usually. They are, the macrolimus, a month supply, not a month supply, 3-month supply. 3-month supply of temecrolimus is $600. That's pricey. The generic tacrolimus, 3-month supply is $380. So they're not cheap. The steroids are easily half that price. So you get some itching, burning, but that tends to be transient, and stinging, and some redness. Sometimes you can also have increased risk of viral skin infections. There are reports of increased risk of lymphoma that's not been confirmed. So that's maybe kind of sort of. Cysparol is a newer drug, and it is a phosphodiesterase 4 inhibitor. Phosphodiesterase 4 degrades cyclic AMP. The increased cyclic AMP levels inside the cells seems to suppress inflammation. The systemic absorption is quite low. It's a 2% ointment. You apply it twice a day. Some stinging and burning at the site of application. Rashes have been reported, but they're quite rare. It's also quite safe in infants and children. There's not enough information about pregnancy and lactation. So what's your provider going to say? Since we don't know, we don't use. If you're pregnant, we err on the side of caution. Coal tar. Coal tar used to be used quite a bit. Now it's been restricted to shampoos. How coal tar works, nobody really knows. Some people say it causes folliculitis, skin irritation, and some photosensitivity. In shampoos, they don't tend to do that. In the shampoos, they get washed off really well. Coal tars tend to take oils that you might have gotten from plants or something like that and tend to get rid of them. They might be kind of odoriferous, but when combined in a shampoo, that's not much of an issue. So coal tars, usually, you're only going to find them in shampoos, like this one here. Yeah. Or poison oak, which I don't think you have poison oak in Michigan, but it's all over California. Boy, howdy. The mountains, yeah. So phototherapy is administered 2 to 3 times a week. You discontinue it after 4 to 8 weeks. Might cause itching, might cause burning, stinging, dryness, redness, erythema, tenderness, and it might alter skin pigmentation. It is, however, safe during pregnancy. If you're breastfeeding, don't breastfeed for 24 hours after getting phototherapy. These come now as lights that you can either buy or take home and use. Some people, these are a drug-free way to avoid atopic dermatitis. Yes? No. That's different. That's different. Then a bunch of if those don't work, then you pull out the big guns. These are big guns. These are immunosuppressors. And these have a lot of side effects. And I just listed them here because we'll go over these when we talk about immunosuppressants, but with the exception of dupilumab, these can have some pretty nasty side effects, except for oral antihistamines, especially the new generation oral antihistamines. And then there's some other drugs, and these are, yeah, problematic, to say the least. Okay, we are out of time. So Monday, we will cover acne, then we'll cover psoriasis. Then we are going to swing around and do chapter 7. And we'll do the antimicrobials because we went over antimicrobials in some detail last semester. I'm going to fly through the antimicrobials. And so what I suggest you do is formulate some questions you might have that you just didn't ask, or as you've thought about it some more, maybe you have new questions, and bring your questions and ask them, because I'm going to just fly through stuff very quickly. Okay? All right. Have a great weekend. I will see you guys on Monday. Go ahead and take one for the road if you want, and I'll see you then. Yeah.
And you also have like some
Yeah. Yeah. The case study, first one will be due probably, I'll send an email out, but that'll be due pretty soon.